Hello and welcome to today's webinar, Preparing and Responding to Natural Disasters, Healthcare for the Homeless Perspectives. My name is Brett Poe and I will be the moderator for the webinar presented by the National Healthcare for the Homeless Council as part of our spring virtual training with support from the Health Resources and Services Administration and the Bureau of Primary Health Care. This is a 60-minute presentation with the last 15 minutes reserved for Q&A. There is a chat box below the presentation slides for participant questions and technical issues. Please type your questions or technical issues into the chat box at any time during the presentation. A select number of questions will be answered at the end during the Q&A session. Remaining questions will be logged in and provided to the presenter for written responses after the webinar if possible. If you're having technical issues, you may also call the Council's office at 615-226-2292 for assistance. This session is accredited for one continuing medical education credit hour through Vanderbilt University Medical Center. If you plan on claiming credit, please copy the information located in the CME Information Notes pod at the end of this session and follow the instructions. The text-in code will only be available during this session. Our presenters today are Francis Isbell, CEO of Healthcare for the Homeless Houston, and David Peary, grant writer at Camillus Health Concern Miami. And I will tell you a little bit about our speakers as I move to today's course objectives. Ms. Isbell is the Chief Executive Officer of Healthcare for the Homeless Houston, a federally qualified health center providing care for approximately 8,500 people annually. As the inaugural CEO of Healthcare for the Homeless Houston, Ms. Isbell has been instrumental in bringing together a large number of community-based agencies, healthcare clinicians, educational institutions, and public organizations to forge a common strategic plan to effectively address the health needs of people experiencing homelessness. The primary aim of this consortium is to increase access to quality health care while concurrently reducing costly and ineffective service duplication. Since joining this endeavor in 1998, Ms. Isbell has received numerous local and national awards and recognitions for her work, and 2 of HHH's programs have been cited as national best practices. David is a grants writer and social justice advocate based in Miami, Florida. He most recently helped Miami's Camillus Health Concern obtain an array of grants to provide targeted case management for severely mentally ill persons and to establish its first peer support specialist program. David is also a class representative in the Pottinger v. City of Miami settlement agreement that protects rights of homeless persons to publicly perform life-sustaining activities without fear of arrest. David volunteers on several National Healthcare for the Homeless Council committees and serves as a regional representative for the National Consumer Advisory Board. He has a law degree from George Washington University and works with several civil rights and community-based organizations such as the Florida ACLU and the Jail Diversion Program of the Miami-Dade County Courts. And with that, I will go ahead and pass it over to David.
Okay, thank you. Good morning, everybody, or good afternoon, if you will, if you're on the East Coast. The first portion of this webinar will discuss strategies to proactively engage consumers prior to disasters. Essentially, I'm going to present the boots on the ground consumer perspective, or tennis shoes on the ground, if you will, perspective of the City of Miami and the County of Miami-Dade County's outreach efforts to shelter consumers before Hurricane Irma. Basically, my presentation will take 4 parts. In the first 2 parts, I'm going to discuss the background of Irma's impact on Miami-Dade County, and the rather unprecedented evacuation efforts of the City of Miami. And as you'll see, for the first time in its history, Miami tried to evacuate nearly 250,000 people. About 650,000 people were subject to evacuation orders, which was extraordinary, unprecedented, and presented enormous logistical problems, as you may imagine. These first 2 portions of my presentation are fairly important to set the stage and describe the context of the rather extraordinary steps that were taken by the Miami-Dade County Homeless Trust to conduct outreach and to shelter persons experiencing homelessness. And by the way, words are very important, and so I tend to describe folks as persons experiencing homelessness, but due to time, just to save time and be efficient, I may refer to folks as homeless persons, which I really hate to do. But purely with respect to preserving time, I will use that phrase every now and then. The second two portions of my presentation will discuss the threatened and actual involuntary commitment of homeless persons who refuse shelter. I'll also talk about the lessons learned and suggestions for outreach and engagement in future disasters. Now, we'll first visit the first few basic facts. I want to remind everyone of the scope of Hurricane Irma. Basically, it was a monster storm. I list some of the facts there on the right-hand side. It was the most powerful Atlantic hurricane ever recorded at that time. That was the costliest hurricane up until about 2 weeks later when Hurricane Maria surpassed it and broke all records. And as you know, Hurricane Maria really devastated the Caribbean, especially on Puerto Rico. The last line on that slide is probably the most important in terms of setting the context in which the outreach efforts and many of the decisions were made in terms of evacuation, that this was the first major hurricane to make landfall in Florida since Wilma in 2005. And I can tell you that the mindset of folks in Miami-Dade County was one of palpable fear. Okay, we had gone 12 years since our last major hurricane. As a matter of fact, I came into Miami in 2003, and between 2003 and 2005, in a 14-month period, we had 4 hurricanes. I think it's Ivan, Charlie, Katrina, and Wilma. So I thought hurricanes were, just a matter of course for living in Miami. Then we go 12 years without a hurricane. And I can tell you that each year since 2005, we're expecting a hurricane. We're expecting one. And each year that we didn't get one, we kind of feel like we're about to get our comeuppance, that somehow all the devastation, all the catastrophe is being saved for one huge wallop. So when last year we find out that a Category 5 is heading straight for Miami, I can tell you that there was a fairly widespread sense of panic, a fear of, okay, 12 years worth of devastation that's been saved up is not going to hit us all in one fell swoop. So that gives you a little bit of context for some of the mindset and I think thinking of the government officials and policy makers. Essentially, as I said, Hurricane Irma was a monster hurricane that pretty much covered the entire state of Florida. It caused extensive damage, including 12 deaths at a nursing home in Hollywood, Florida. And this was very tragic. This is beyond the scope of my presentation, but this goes to the need for advanced planning in terms of disasters. This particular nursing home in Hollywood, Florida, lost its power. In fact, it didn't have power for about 2 weeks. And when the electricity went out, the air conditioning went out, and 12 senior citizens died. And so that really points out to the need for advanced planning for those types of facilities holding vulnerable individuals. Another consideration of considerable harm that would occur to the residents of Miami were the presence of multiple construction cranes throughout the city. The crane happens to be, as people jokingly say, the county bird of Miami-Dade County. There happened to be some 35 or I think 25, between 25 to 30 cranes scattered throughout Miami. And these are very, very large construction cranes, especially if you live in the downtown area, near the Central Business District, or near the coast, as I do, then you're going to live within a block or two of a major crane. Now, if you look on the right-hand side, that's actually a cell phone photo that I snapped outside of the window, that I snapped from the window of my bedroom. That's a scene from my bedroom window on September 7th, 2017. That building that you see being constructed was right across the street from me and half a block down. And there happened to be a 35-story tall construction crane. So I woke up every morning, looked out my window, and I saw this 35-story construction crane staring at me. And then I turn on the news, and if you look on the left-hand side, there's this rhetorical question here: can cranes withstand Irma's winds? And basically, the government officials were warning anybody within eye distance of a crane to basically leave, get out. And so I heeded that warning. So I want you to keep that, as I said, rhetorical question in mind as we go through these slides. Can cranes withstand Irma's winds? Because you'll get the answer in about 3 or 4 slides from now. So basically, with all that information in hand, with Irma barreling down on us, the city of Miami, the Miami-Dade County mayor issued unprecedented evacuation orders. The screenshot that you'll see on the left-hand side is that of Miami-Dade County Mayor Carlos Jimenez issuing the evacuation order. To his left, I guess to our right, is Florida Governor Rick Scott. And as I said, this was unprecedented. These orders covered basically 650,000 people. And they strongly advised everyone to leave. Even though this was cast as an evacuation order, if you look at that last paragraph on the right-hand side, and I'll quote this: while often described as mandatory, the orders carry no punishment for people who choose to remain in evacuation zones. That's actually a quote from the Miami Herald that was present in perhaps half a dozen news stories that were discussing the evacuation orders. So the orders were, quote-unquote, mandatory, but they carried no punishment for those who chose to remain in evacuation zones. That's true for people who are housed. That was not true for people that were homeless. As you'll see, these mandatory evacuation orders carried significant consequences for folks that did not have a home. Now, the Miami-Dade Homeless Trust, in collaboration, in partnership with the city of Miami, hit the streets, went out and sought to offer shelter through various homelessness providers, through various emergency shelter providers, to all 1,000 individuals that were estimated to be living in and around the streets of Miami, in and around the evacuation area. According to the latest point-in-time count, there are roughly about 1,000 folks living, homeless folks living in that area. Out of that roughly 1,000 folks, maybe about 200 had self-evacuated, and about 300 of them took up the offer of shelter. So that left about another 400 or 500 people that were still out on the streets 3 or 4 days before the storm. So a decision was made by the head of the Miami-Dade County Homeless Trust to use what's known as the Baker Act to involuntarily commit persons who are homeless to mental health crisis units if they refused shelter. I think most folks are familiar with the Baker Act. I think most states have the Baker Act, or at least a version of it. In Florida, it's called the Baker Act. But essentially, this law provides for a 72-hour involuntary commitment of individuals if a mental health professional determines that this individual is either a harm to other people or is a danger to themselves. Now, the way that the Baker Act procedure goes, when a police officer determines that a person meets the criteria for being Baker Acted, they'll cuff that person, they'll put them into a back seat of a police car, and they'll drive them to the nearest crisis unit. In central Miami, the nearest crisis unit was this area called Jackson Hospital System Crisis Center. And then that person is then examined by a mental health professional who would then certify that this person meets the criteria, i.e. is a harm to themselves or to others. And then that person will be held for 72 hours. And then another assessment will be made after that 72-hour period. Now, this decision to Baker Act homeless individuals who refused shelter was, as you may imagine, highly controversial. It actually made headlines and stories throughout the nation. The Associated Press picked up on it. If you look on the right-hand side, these are all screenshots of various news stories. But the Associated Press picked up on it, and these stories got circulated through the Chicago Tribune, the LA Times, and basically through papers throughout the nation. How many people were Baker Acted? And how many people were threatened with the Baker Act? The answer to those questions appear, or at least a partial answer to those questions, appear within a post-Hurricane Irma report that was issued by the Miami-Dade County. It's a 68-page report that on page 21 discusses the decision of the Homeless Trust to Baker Act individuals that refused shelter. The last paragraph says, in the end, 6 individuals are certified after evaluation by a psychiatrist and taken to Jackson's Crisis Stabilization Unit for care. Once again, Jackson refers to Jackson Hospital, which is the major public health institution within Miami. Of the 6, only 1 ended up remaining after the second evaluation at the Crisis Stabilization Unit. That meant that 1 person out of those 6 stayed longer than that 72-hour period. But that doesn't tell the whole story. Here is really the major part of the story. Outside of the 6 people that were actually Baker Acted, there are up to 25 people that are threatened with being Baker Acted. And from my perspective and talking to people actually on the streets, and I happen to know a fair number of chronically homeless who are living on the streets at that time, 25 was actually at the lower level. That was actually far more than 25 individuals that were being threatened with Baker Act. So what does this mean? That they're, quote unquote, voluntarily decided to enter a shelter after being threatened with being Baker Acted? What that meant was that the police, along with a mental health professional, would approach folks that were still on the sidewalk, still on the streets, and if they refused shelter, they handcuffed them and they put them into the back seat of a police car. And after sitting in the back seat of a police car for maybe a few minutes, that person suddenly had an epiphany or suddenly had a change of mind and, quote unquote, voluntarily decided to enter shelter. You know, whether this is truly voluntary or not, I'll leave that up to other people to, to conclude. But I can say that sitting in the backseat of a police car while being handcuffed is certainly a very strong argument for examining your other options. I'll also take a moment to just quickly discuss why would a homeless person refuse shelter in the face of this monster storm approaching. And I think it's probably the same reason why many people who are living in million-dollar condominiums might refuse shelter, even when faced with the prospect of being swept out to sea, even while you're sitting in your million-dollar condo. This, once again, was at one point, we were looking at a hurricane, Category 5 hurricane actually hitting Miami. And I think the same considerations happen, to folks that are both homeless and not homeless. This is where you reside. This is where you're familiar with. Your possessions and your friends are there. So I think the same considerations hit folks, whether they're homeless or not, in terms of whether to shelter in place or whether to evacuate. However, once again, the liabilities were very different for the folks or the consequences were very different for the folks that were not sheltered. So let me quickly go through these slides. Remember the question that I asked previously as to whether the cranes would withstand the winds, and the answer was several of them were not able to withstand the wind. Several of them snapped under pressure. They were supposed to withstand wind speeds of up to 140 miles an hour, but unfortunately, wind speeds up to 90 miles an hour caused some of these cranes to fail. The hurricane caused massive flooding throughout the city. There was actual massive wind damage throughout the city. As a matter of fact, I evacuated the shelter. When I came back to my apartment building, my roof was taken off, and so I actually had to relocate to a Red Cross disaster shelter. And here are some scenes from the Red Cross disaster shelter for those of you who have never had the pleasure of spending some time within one. This was a very large room at Florida International University. It's an exhibition hall where I got to spend about a week with 2,000 of my closest friends. And the pictures that you see were actually taken at lunchtime. And if you look closely in the back, you'll see long lines of folks actually lining up to receive their lunch trays, and you'll see numerous cots. There are two very large rooms that held about 2,000 people. They did try to ease the pain somewhat. On the left-hand side, you'll see three violinists that came in. It's actually a father, son, and daughter that played violin music for everybody, which you could barely hear above the den of 2,000 people, but it was a very nice gesture. The FIU cheer squad came out and performed for us. The lady at the bottom there, that nurse, is a remarkable person. She was actually at Hurricane Katrina in the Superdome, and she actually spent a lot of time in Houston at Hurricane Harvey, and she flew up to help us out with Irma. Now, on the right-hand side, you'll see that we did get coffee and donuts in the morning, guarded by a Miami-Dade County police officer. So let me quickly go through the lessons learned, and some suggestions in terms of future proactive engagement of consumers. First, strong recommendation is to use peer support specialists and your consumer advisory board. The peer support specialists, as most people know, have that lived experience of homelessness or recovery from substance abuse or mental health issues. And these are the perfect people to engage, to speak the same language as individuals that you're trying to reach. So I highly strongly recommend that when you're seeking to engage in terms of outreach, that you use the resources of your CAB and use the resources of your peer support specialists. The National Healthcare for the Homeless Council also has certain resources. This is a screenshot of a 2009 paper on disaster planning for people experiencing homelessness. There's also a 2015 issues brief as well. Both of these, all these documents basically emphasize the need to use trauma-informed care tools towards engaging individuals. Do not compound the trauma, which I'm going to talk about in just a moment, by compelling them to do things or making things worse, because trauma doesn't just show up in the first 24 hours and then just goes away, but trauma can last, as we can see from Hurricane Katrina, for years, for many, many years afterwards. And we don't need to compound that trauma through our evacuation efforts. And third of all, HUD and your local continuum of care organization certainly has resources. This screenshot that I'm presenting here is an excellent resource from HUD. This is a two-page disaster planning guide, and I highly recommend folks to take advantage of that and to use that as a resource. And I believe that Francis, the next part of our presentation, will talk about that a little bit more. Here's what not to do. I believe that involuntarily committing homeless persons during hurricanes is a last-ditch emergency effort that probably should be avoided. I think this points out to some of the systemic failures within the system that we'd have to go through that need to involuntarily commit individuals. And this, by the way, this David Perry on this paper is not me. I'm a David Perry. But this is not me that authored this, but this is an excellent paper that I can certainly send to folks if you give me your contact information. the national, and I was remiss in not putting this on a slide, but the National Council on Disabilities also issued a paper discussing the discrimination during Hurricane Katrina, the discrimination against persons with psychiatric disabilities in the city of New Orleans, preparation, response, and recovery from Hurricane Katrina. And that contains some very relevant findings and some very useful recommendations in terms of outreach and evacuation of homeless persons. But basically, the problem here is that the county simply did not plan for the contingency of what to do about individuals who are homeless who are refusing shelter. That simply was not included within their disaster planning process. So, hurricanes are not an unusual occurrence in Miami. As a matter of fact, that's the name of our local college team at the University of Miami. That should be included within any disaster planning process, what to do about folks, who refuse shelter. But even before that, there has to be outreach, there has to be establishing the proper proactive, positive relationships with folks, using your outreach, using your peer support, using your CAB. So my portion of the presentation is now over. I am very happy to give folks the link to the National Council on Disabilities paper. As I said, it's a very, very significant and very useful paper for planning in terms of outreach, and its findings and its conclusions are directly relevant to this issue of how to effectively engage consumers and useful proactive strategies for outreach prior to disasters. So please contact me at perrylaw@gmail.com, and I'd be very happy to send you a copy of that paper. So at this point, I'm going to go ahead and turn this over to my co-presenter, Francis. Thank you.
Hello, everyone, and thank you for joining us. Before I move into the presentation, one of the things I want to do is kind of have a caveat. The council asked me to make this, to participate in this presentation, but I am by no means an expert on disaster preparedness and response. I think that what I do have is a lot of experience based on the last 20 years of running healthcare for the homeless Houston. So just know that I'm not necessarily the go-to person all the time. What I'm going to do is I'm going to divide the presentation into 3 different areas: preparedness, response, and recovery, which is really the way to try to divide your emergency response plan. And like David said, there are some really great resources to try to help guide you as you develop a plan. HRSA and the Bureau of Primary Health Care put out some guidelines. FEMA, because Centers for Medicaid and Medicare have good guidelines. The National Association of Community Health Centers have good guidelines, and then especially the National Healthcare for the Homeless Council have a wealth of information on their website. So if you go onto the website, there's a lot that you can learn, and it's just great guides. One thing to remember is that if you are in a federally qualified health center, there are certain requirements that HRSA has for your plan. So be sure and look on the HRSA website to make sure that your plan is compliant with those requirements. One of the things that I think is really important in preparing for a natural disaster is that staff understand their roles and responsibilities, and especially your management or leadership staff. This is one of the areas that I think that we keep on learning and getting maybe a little bit better about, but I think we still have a lot of room to grow, and that is making sure that your staff is well in service with your plan. We go over things like emergency planning, active shooter types of things with the staff on a fairly routine basis. Every time there's some kind of a storm event, we go over the communication plan, etc. But I think that this is just one of the areas that we could certainly do better in. And one of the things I also want to talk about is, and I'm going to kind of come back to this several times throughout the presentation, is that I think it's really important to prioritize staff safety and to remember that the staff have to be safe before they can really respond to your patients and clients. Sorry, that was my other telephone. So again, I'm going to come back to that over and over. One of the things that I think is important in the preparedness stage, and this does take a lot of effort, is to coordinate with other community planning. And a lot of that has to do with how, in terms of how well you can do that, has to do with things like, are you in a rural area? Are you in an urban area? If you're in a very large urban area like Houston, is there a good coordination throughout the city and the county? So we have been very fortunate to be involved with both the city planning and the county planning, and coordinating with the Department of Homeland Security. And I think one of the things, even though this does take a lot of staff time and staff resource, it's important to try to become a known resource for your patients and your clients, so that officials come to you and ask you kind of how, what are your recommendations and how you can participate. It's obviously very important to coordinate with other providers that have outreach teams. So in our city, there are 4 or 5 agencies that have significant outreach teams that go out and work specifically with the folks that are living on the streets. Then a couple of things that we're fortunate with. I know on the National Healthcare for the Homeless Council's, their website, that one of the studies that they have indicate that a lot of times people that are living on the streets are going to be more frightened if the police show up than one would want, and that is constructive. And we're very fortunate, both the Houston Police Department and the Harris County Sheriff's Office have homeless outreach teams. And these are teams that are set up specifically to work with people that are living on the streets. And so they get to know people, and people that are on the streets have good relationships with these teams. And that both of those teams helped in the days leading up to Hurricane Harvey, trying to help get people into shelters. The volunteer organizations active in disasters, VOAD, most major cities have one of these organizations, and they're good to work with. And then certainly different state primary care associations. Throughout every hurricane, our primary care association has really kind of led a lot of coordinating efforts. One of the things that I would say, if you have not done this, join Direct Relief and AmeriCares. Not only will you be able to receive free pharmaceuticals and medical supplies throughout the year, but I can't tell you how helpful they were throughout every single hurricane that we have experienced since I've been CEO of Healthcare for the Homeless Houston. They are on the ground typically before an event happens and are directly involved with each one of their member organizations. So I can't tell you and encourage you strongly enough to join them before an event happens. So another thing that I think is really important is to have a good communication plan. There was significant improvement between Hurricane Ike, which happened in 2009, and Hurricane Harvey, which happened last year. And with Hurricane Ike, it was about the only way that you could communicate with other staff members was through texting. And a text, it's quite possible, might take 2 or 3 hours to actually get to the recipient. And it's because, the bandwidth was it just couldn't handle that kind of traffic. Getting calls through were almost impossible. So even though we had a fairly good communication plan among the staff, it didn't work well. In Hurricane Harvey, the technology was incredible. The texting was easy. Typically, the phone calls were easy as well, and part of that's just the increase of the bandwidth in the city. The other thing was there were technological advances in terms of the city being able to communicate, the city and the county being able to communicate directly over text. For example, and this didn't have anything to do with Healthcare for the Homeless Houston, but one of my daughters and her family lived in one of the areas that was going to be flooded when the reservoir waters were released. And so that was obviously a very frightening experience. But there was a way to turn your cell phone into a walkie-talkie. So you had to download an app, and it would turn your cell phone into this walkie-talkie, so that as the people that were in that area were evacuated, and they all had to be evacuated either through a helicopter or through an airboat, there was a way to communicate with the people that were in the houses so that they were able to say, okay, you're number 34th on the list, and we expect somebody to be there within 2 hours. And okay, now you're number 32 on the list, and we expect somebody to be there within, an hour and a half. So the technology has improved significantly. We were able to stay in contact with our staff almost constantly. Within 24 hours, the leadership of our organization knew who had been hit badly, who may have been hurt, who had been evacuated, etc. And so we were able to make that connection with people. One of the things that is supposed to be in everybody's emergency preparedness plans is to have a good communication plan with your patients. That's obviously going to be much more challenging if your targeted patient population are people that are homeless, whether or not they're literally living on the streets or not. That, I think, continues to be a challenge for us. For example, we had one staff member that lives very close to our main clinic. She was able to come over within about 48 hours to check on the clinic, and there were people that were patients of ours that were waiting in line, even though we had tried to communicate. We had done a lot of outreach work and had a sign on the door saying that we weren't sure when we would be open again, and people were there trying to get basic needs met. So the communication is obviously a big challenge for us. Then I think another lesson that we actually learned the last time we had an event was to plan for post-event calls of the leadership, so that as soon, within 48 hours, we had leadership calls that were planned for 10 o'clock in the morning and 4 o'clock in the afternoon, and to touch base and to try to start planning for reopening at least one of our clinics. And again, that was really important because one of our clinics had lost power, would not be able to be open for a week because of the loss of power, but we were able to open our main clinic 4 days after the hurricane hit with a volunteer staff crew, and we were able to try to coordinate with the staff that could get in order to open up on a part-time basis. So most of the natural events that happen in Houston are going to include hurricanes, mass flooding, and then sometimes tornadoes. But typically it's going to be hurricanes and flooding. And in most cases, especially with hurricanes, we're going to have enough warning time so that we can prepare. I think it's really important, again, to remember staff safety needs to come first, and that staff are going to need to prepare themselves, their homes, their families, etc. So often we have been able to give the staff some time off before we know the hurricane is going to hit, so that they're able to get home, make the preparations they need to make, and try to keep them and their families safe. Another thing that we were able to do this time that was really important is, as we knew that the hurricane was coming and that it was quite likely it was going to hit Houston, then our provider staff began going through their records, looking for patients who were more than likely going to run out of medications, and looking through their medication list. And then the support staff, were able to try to make calls to those patients, trying to get them into the clinic so that we could make sure that they had enough medication to make it through the hurricane and recovery period. Then one thing I think is also important to remember is that for people that are still living on the streets, just like with people that are housed, often the decision to go into a shelter is going to be very last minute. And the reasons that people, I think David touched on this, often the reasons that people talk about for not going into the shelter is that they're frightened of losing their possessions and don't want to go into a large shelter. Often if somebody is going to go into the shelter, it'll be very last minute. Our outreach teams, about maybe the last day before the hurricane hit, what they started to do was take basic necessities out to people that they knew were not going to go into the shelter. So then let's move into the response stage. Again, trying to take care of your staff is going to take precedence over everything. At least that's my opinion, and it's been my experience that that has worked well. One of the things that does happen is that people are anxious to know how other people are, whether or not anybody is hurt, whether or not they've been really severely affected. Several of our staff lost their homes, had very, very severe damage to their homes, had to be evacuated, and the staff care about each other. And so the sooner you can get information out to people about, who's doing well, who didn't have any major damage, who did have major damage, whether or not anybody is hurt, whether or not their family members are hurt. This helps, I think, to ultimately reduce anxiety, and that's certainly one of the things you want to try to do, is to reduce anxiety of both your staff and your patient population. Often, the people that are able to get into the shelters, and that varies widely, at least for us. There were people who, and this was true for me, I couldn't even get out of my neighborhood for several days, and there were other people who couldn't get out of their neighborhoods for over a week. But there were people that could get to one of the major shelters. We had 2 primary shelters. They were very large, had thousands of people in them, and people naturally want to volunteer to try to help. That has the potential, obviously, to create some scheduling problems when you are trying to open up the clinic. But I think that's a balancing act, because people do want to feel like they are contributing to the greater good of the community, as well as coming back and volunteering to open up in the clinics. One of the things that was a challenge for us is that pretty quickly we had a team of people that included both primary care providers, behavioral health staff, case managers, medical assistants. There was a team that was actually able to get into one of the major shelters. They got together, they went to the shelter, and FEMA was running that particular shelter, and the FEMA staff turned them away, which was just kind of shocking to us. We wanted to go in and provide care for our patients. And they, I don't know what their reason was. I think it was, at that point, they were probably just overwhelmed with the chaos of, thousands of people in the shelter. But they said that they didn't want the team that came in. Later, as there were more and more behavioral health and substance use issues that were popping up, at that point then they asked for more help from our staff. And there were other smaller shelters around town that were providing shelter space that then asked for our help as well, and we were able to get behavioral health staff out there. The other thing that I think is important to remember is that some folks that live on the streets, they may go into the shelter for the time that's just the immediate danger, and then will immediately leave following the danger. They want to get out within 24 hours as soon as, like I said, the immediate danger is over. And so then that then becomes another kind of scheduling issue, is how to kind of beef up your outreach to try to reach out to these folks that have already gone back. And part of the issues, I think, for wanting to leave the shelter as soon as possible, people that have serious mental illness and are not able to really withstand how chaotic and loud the shelters are. And then part of it is for folks that are using drugs. They want to get to a place where there's not a lot of police presence. So we have had some unfortunate experiences working in the shelters in many of the, especially hurricane and flooding disasters. One of the things that the National Healthcare for the Homeless Council staff are helping with is to try to work to educate both FEMA and Red Cross and some of the other national response teams that that treating people who are living on the streets differently than people who are coming into the shelters that were housed is really unproductive. One of my biggest complaints is that as people come into the shelters and are being registered, from the very beginning they are asked, were you homeless before the hurricane? And so even just walking into the shelter, they begin to be treated very differently. I think that that they're not seen as having lost their home. FEMA won't even pay for some of the services later on if someone was on the streets before the hurricane. So I think that hopefully this is more an educational issue than anything else, but it's something that I feel very, very passionately about. In terms of the shelters themselves, like I said, they're very loud, they're very chaotic. Obviously people are under a lot of stress, they're frightened, they're anxious, and so that leads to a lot of just unrest within the population, within the folks that are staying in the shelters themselves. I think it's, and David mentioned this, I think it's really important to remember that for many people this is going to include secondary trauma. The other thing I think is that the volunteers themselves, they report feeling really overwhelmed when people that are living on the streets come to them for assistance. And so part of what they do is they'll say, well, if you were homeless before the event, then what we want you to do is to go back and continue to provide or ask for services within the homeless provider team. And in some ways that makes sense, because people that are providers for folks that are living on the streets, well, we're very, this is what we do. On the other hand, it's not as if there's suddenly a whole lot of new resources that are being funneled into the area, into the homeless response system. And so, there's a kind of a mismatch here. So once we get through the immediate response, then response period, and interestingly enough, usually that might last for a hurricane, really last a matter of hours, possibly 10, 12 hours, actually is the event. For Hurricane Harvey, that actually lasted over 3 days. The hurricane came and went within a matter of hours, and there was an incredible rain event. But it wasn't until 3 days later that the massive flooding started, and so the response time actually was much longer than is typical for us. So then recovery, one thing again I want to talk about is the staff, and that is assessing the well-being of the staff on a pretty regular basis. And that has to, you have to work with your management team, your leadership team, so that each department is reporting in, and we're able to try to keep tabs of how the staff is doing. We were able to offer several groups for the staff as well as for the patients and clients. Groups where people could just talk about what was going on with them, talk about the stress that they were under. Everybody in our city was traumatized. This was an event that we had never experienced before. We were not prepared for how massive the flooding was going to be. And I think that, I remember there being just this feeling of heaviness in the city. People joke and talk about the Astros winning, but you could feel just this palpable difference once the Astros did win the World Series. That really did help 3 weeks later for the city to kind of come back and wake up from being so traumatized. I remember myself, and my home did not flood, but I remember about a week after the hurricane, there was another really big rainstorm, and I was in my car, and it started just raining again, and really loud thunder. And I realized my hands were just gripping the steering wheel, because I just felt this stress of and I thought of, oh my goodness, don't let this happen again. So it's really important to try to stay on top of the well-being of your staff and trying to take care of your staff as well as your patients and clients. Obviously, one of the first things you want to do during the recovery phase is also assess your facilities and equipment. And again, I would stress being members of AmeriCares and Direct Relief before anything like this happens. Both AmeriCares and Direct Relief not only provided additional pharmaceuticals and medical supplies, but both of them gave grants to FQHCs and charity clinics to try to recover from any facilities damage. We were fortunate we had some damage, but it was not really significant. There were other FQHCs that lost whole clinics. And so AmeriCares and Direct Relief can't obviously give millions of dollars to help a particular FQHC rebuild a clinic, but they were able to provide a lot of financial help in refurbishing facilities. Again, I think that one of the things that we did well was have these twice daily meetings with the leadership so that we were able to plan to reopen one of our clinics within 4 days with this kind of skeleton crew. So I think it's imperative to start that planning. It's also imperative to know which one of your staff are going to be able to make it in and when. Some of our staff had to be out for 2 weeks. By then, almost all of the flooding was down. But Houston Independent School District, where most of our staff, their kids go to HISD, HISD was closed for 2 weeks. And so unless somebody was able to arrange for other daycare, then they weren't able to come in for 2 weeks. So, starting to piece together scheduling and staffing is one of the things to start happening. The other thing I think that David talked about is involving your Consumer Advisory Board. So obviously they have invaluable wisdom. We have involved our Consumer Advisory Board with emergency planning and with our preparedness plan. They also, I was able to reach out to the chair of our Consumer Advisory Board, and as we were preparing for Harvey to hit, and several members of our Consumer Advisory Board actually helped us in our outreach efforts, trying to get to people that were living on the streets and encourage them to get into the shelter as the hurricane was coming to town. The other thing I would say is I think it's really important to be a very vocal advocate as Healthcare for the Homeless programs or as a Healthcare for the Homeless program within a larger community health center. We really do have the voice of experience and to some degree expertise. I was able to talk to the city health department and our city medical director and fairly quickly about our experience being turned away from the one of the largest shelters here, and they were just appalled and got on, started getting involved immediately trying to rectify that situation. So I think that it's really important to have those relationships established early on, again, so that you're recognized as an expert in providing care, and that assists you in being a real advocate for the people that you serve. One of the things that was also just really sad to me and very frustrating at the same time is that there was just very little understanding with people that were working within the shelters that someone that lost all of their possessions in an encampment lost their home too. And they were just as traumatized as someone who was housed before the hurricane and lost their house during the, their physical structure. They were traumatized, but so were the people that lost everything that they had in their encampments. One good thing that did happen was that for some of the people that were in the shelter that had been living on the streets before the hurricane were actually able to be prioritized for housing. Many of the people that came to the clinic immediately following the hurricane were really seeking basic necessities, food, water, drinking water, those kinds of things. So we've learned that over the years. So one of the things we start doing is working with the Houston Food Bank, as well as making sure that we have shelf-stable food, a supply of that, a supply of blankets, a supply of clothing, etc., because we know that people are going to be coming to us for those things. One of the things that did happen, again, it's very sad, was that there were 3 men who were living on the streets who died in the flooding. 2 from Houston, 1 from a small town close to Houston. And many people that came to us, they may not have known those people personally, but felt the need to have some way to honor them and to grieve. And so there was a ceremony that was provided. We actually weren't part of the group that organized that, but were able to refer people to that, that ceremony for the people that died during the flood. There's typically a pretty sharp increase in behavioral health issues, and you know, there's a lot of secondary trauma, a lot of anxiety, a lot of stress. So this is also one of the things that we always prepare for. One thing that I would say, the last kind of lessons learned, people say over and over that a hurricane like Hurricane Harvey is classless and raceless, and I think that that is true. The response is incredible during the event and immediately following the event. That is not true of recovery. People's ability to respond after the event really is affected by social determinants of health, and I think that that's important not only for us as providers to remember, but also for our communities to remember that. The other thing is that this kind of stress takes a long time to heal from, both for the staff and for the people that we serve. And I think there just has to be a lot of allowance for that, especially, you know, with your staff. Another thing that I think is important, especially for administrators, is that trying to manage response and recovery takes a tremendous amount of time. You know, the first 2 weeks, basically what my job consisted of was trying to navigate through the different, you know, trying to set things up, trying to respond to people that wanted to help, etc. So it really, it was kind of a command position rather than my normal job. And then the last thing I would say is that there are always lessons to learn. Every single time we learn something, every single time we update our emergency preparedness plan, etc., there's always something that we learn. And with that, I'm going to end.
Great. Thank you so much, Francis and David, for presenting today. I know that it's been really beneficial for us in how we all think about local policies and practices in the event and in the aftermath of natural disasters, and how those can apply to the experiences as they relate to the communities for our participants today. So thank you to our participants for joining today's webinar. A link of the archived webinar will be available on our website at www.nhchc.org at the conclusion of our spring virtual training, and so those will be made available during the week of March 19th. Again, please copy and follow the instructions to claim your CME credit for this session, and that's available in the CME information pod on your screen. The text-in code will only be available now, and credit must be claimed within 24 hours. And a survey will be delivered to you